feel you might be under a sort of misapprehension, is that the word? Although it gives me a title of Life Fellow of the Royal Society of Medicine, I am a Life Fellow. In fact, I was Vice President for a while a few years ago. But I'm not a doctor, clinician. I was a nurse by background and then became a NHS manager. And then I moved into running a patient safety organisation for 10 years, and that's where Natasha and I met up. And then we closed down that organisation, transferred our assets into the RSM, and we set up the patient safety section. Now, I'm mainly a carer and involved with health and social care research. I have a husband with dementia, advanced dementia, and I have a mother with dementia, and she's 102 next week. And so I know a lot about dementia. I represent carers. I run a carers experts by experience group, and I'm very much involved in local care issues. I'm also a chair of a patient participation group for a local health centre. So I sort of, dare I say it, I cross the divide. My interest is joined up thinking. So there we are. I think my presentation is going to be rather more down to the coal face than our previous speaker. But I hope, I looked at the delegate list. I always ask for it to be sent through to me. And I see there are obstetricians and all sorts of people that probably are not particularly interested in elderly care, but maybe they are because they might have
everyone's got a mother and father,
parents or whatever. But I'll try and make it sort of not, you know, what shall I say? I hope you enjoy listening. So I always record myself, awful thing to do, but then I can hear, you know, about how it went off, etc., etc. So if I can get this, I haven't got a lot of time, but let me just, that's it, it's supposed to be a recording. So, I imagine sorry?
You've got till 1.
1 o'clock, yes, and then I've got to dash off, so I can go somewhere else. Right, is it the button? A minute. Which one? Not moving. Aha, there we are. Improving care for older people, there we are. I think I went the wrong way. Now we're back. Not working. Right, it's the laser, I see. Right, there we are. Okay, so I thought we'd just give set the scene, as it were. And I wanted to set the scene by saying many of us are pretty healthy, actually. And a lot of us are extremely active, like myself and others. We're often carers, might I add. Many carers of older people are into their 80s, 90s, and have their own health problems quite frequently. And therefore, we do provide a lot of support, if you like, peer support to each other, but also are very active in the community. A lot of us are. But the ageing population does mean that there are many more people living with long-term conditions and with varying degrees of functional, sensory and cognitive impairment. And we obviously know that. And here's just a few facts. In 1948, at the inception of the NHS, nearly half the population died before they reached 65. I mean, really, that's quite sobering, isn't it? And how far we have gone now, because in 2010, the average life expectancy is 78 years for men, and 82 for women. And if you reach 70, and I've reached 70, your average life expectancy is 17 years for men and 19 years for women. And maybe mine's quite a bit longer with a mother of 102, but I'm not sure I want to live that long. It's has its moments, if you like. So during the past 10 years, and many of you will know these facts better than I do, 37% increase in emergency admissions to hospital. And we hear all the time about trying to prevent people arriving at emergency accident and emergency departments. And there's been a 67% increase in acute inpatient episodes of the over 75s. 65% of hospital admissions, 70% of bed days in general hospitals are now patients over 65. Now, I remember way back, I started my training at Westminster Hospital in the 60s, and I did a bit of research at that time, and I just remember the figure of only 5% of patients in an acute general hospital at that time being over 65. And I can remember that all too well during my training and afterwards, that actually elderly people on the wards were quite infrequent. You might have one or two on each ward. And people had real medical conditions like mitral stenosis from rheumatic fever and, you know, all this sort of tuberculosis, all the bog standard medical conditions of the past. And yes, it was real nursing around that time, because our drug cupboard was just a few shelves in a little cupboard on the wards. And I can still remember some of the names of them, but there were only about, I don't know, about 30 drugs, I should think. You know, one diuretic and a couple for the heart. And, you know, it was a different world, and of course antibiotics. But really, life was very different then. And look at this at the bottom, about 1 in 4 adult beds is now occupied by somebody with dementia. And even I can't really believe that, but that's a statistic. So this is what the Royal College of Physicians recently said: the time for action, hospitals on the edge. It is increasingly clear that our hospitals are struggling to cope with the challenge of an ageing population and increasing hospital admissions. Well, that we all know that, don't we? And here's another one, Steve Dorrell, as far back as 2011, well, no, it's only last year, isn't it, in the Health Service Journal. Systems designed to treat occasional episodes of care for normal, healthy people are being used to deliver care to people who have complex and long-term conditions. And you can read the rest. But silo to silo, oh yes. I mean, this, I think, is, you know, it does say very well. It's a very good illustration of how the scene is now. Description. So I sort of did a bit of brainstorming, and obviously in my work I work with a lot of older people on a voluntary basis. And we say time and time again, people give this list of what they really need. And this is what would help them keep out of hospital, or for the carers to help the person they care for keep out of hospital. Early information concerning support available and signposting from their general practitioner. Now, I don't know if any of you are general practitioners here, but at a recent meeting of our PPG, and we're a pretty good health centre, happened to be in Richmond upon Thames, and you know, it's what shall I say, it's not the most difficult area to work in. And we discussed these issues, and I said, you know, because I've worked in patient safety, so many of the problems that occur are along the patient pathway. You don't have a pathway, actually. You're seen by the GP, who, I'll just stop there. If you go in with your husband or wife with memory loss and the GP sees them, at that point, if you are the carer or possibly the patient, you are very anxious to, you want to be better informed about the condition, and you also want to be better informed about what's out there in the community that can help you and support you. Because actually, by the time you've got there, they talk about early diagnosis, but actually often one finds it's quite difficult to get the person with memory loss in front of a GP for quite a while. So by the time they get there, they're quite a way down the line. And the poor old carer is pretty desperate by that time. and they really want information. Well, I suggested, you know, I said, really, this is what people with chronic conditions want. And the answer from the practice manager was, well, you know, GPs see so many people with so many conditions, they couldn't possibly have that information at their fingertips. Now, I know you have information systems, but this is where it really falls down right at the start, because the patient is then referred on, possibly, into secondary care for memory testing and medication and all the rest. And they sort of feel bewildered. They wait for their appointment and they just don't know what to do. And unless they're pretty sort of savvy and are, you know, they have enough, what shall I say, drive in them to seek further information. It's amazing how far people get down the line, really floundering on their own. So I would say with any condition, we need a lot more organisation at GP level. It doesn't have to be the GP, it could be within the practice. And it will be interesting to see what happens with clinical commissioning. And the GPs taking on a lot more responsibility. But really, it's just not good enough. And in fact, it's not safe, because for varying conditions, I'm only mentioning it in relation to dementia, people can drop through the net very quickly. They don't get an appointment, and then there's delayed diagnosis and all the rest. And I've seen that happen with disastrous results. They also want the GP to share information, and they want to. Most people, not all of them, obviously there has to be judgment there, but most people really feel they want to be empowered. They want to know what's going on. They don't just want to be pushed off to another health professional. I've got limited time, so I must move on, but I'm just putting these ideas into your heads. And then if somebody does have a chronic condition, they can often avoid that emergency admission if only they're given better support in the community. And certainly that I know, because I'm involved with clinical commissioning and what's going on in the local environment. Various models are beginning to be looked at and have been looked at around the country, where teams come together of health and social care personnel within a team and provide really intensive support in the community. And that's what's going to happen. On the other hand, I know of a situation, because I'm involved with research at a local hospital, when we don't like the term, but they're doing some research into the virtual ward of patients coming in with specific acute medical conditions, and then not admitting them, seeing them on the ward, evaluating them, putting them on their medication, etc., and then treating them as outpatients. So it's going from both directions, and some of you must be involved in these sorts of ideas, and I just wonder where it's going to go in relation to commissioning, because there's people sort of from community thinking about what they can do to provide better support. There's also people from acute care wanting to hang on to the money and thinking what they can do. So there we are. It's a very interesting new world. And then, this is something I'm particularly interested in, but another question I asked of our practice managers: shouldn't GPs, because they're trying to avoid people going to accident and emergency, shouldn't they routinely follow up and call anybody in who has attended an accident and emergency department? To me, it just seems sort of common sense, you know. They arrived there, collapsed or whatever. I would have thought they need to be seen. That isn't routine, you know. I'm told it's just not possible. We just haven't got time. So, you know, I don't know. I'm making no judgment, but to me, there's a whole issue around following up patients and really, if you like, providing a care pathway or a mini care pathway, having models in place that really do look after the patient while they're within an episode of care. And then, of course, at the bottom, I put clear advice about what to do when needing clear information about what to do when needing urgent advice, urgent information in a situation, acute emergency. And that is also a big problem. I've been there myself, you know, whether you take the person you care for to the GP, whether they can deal with it, whether you ought to go straight to A&E. And I've done made various decisions at various times. And usually I've landed up in A&E. You know, one just lands up there because either you're directed by NHS Direct or your GP says I can't deal with it and the patient goes off to hospital. There we are. But I must move on. Why do elderly people attend A&E departments? Falls is a major issue, as many of you must know. Otherwise, they have the normal illnesses related to perhaps heart problems or diabetes or transient ischemic attacks, whatever. But falls are quite a high percentage, as it has here, 1/3. And they often have complex medical and social needs over and above the clinical cause of attendance. And those don't always get a look in A&E or during the sort of period before discharge from the hospital. These are obviously standard, and I don't think I'm going to go through them because of timing, but obviously you've got to take an accurate history, and that's a problem with junior doctors seeing elderly people in hospital and being very pushed. I've had it myself. Won't go into my personal history, but a few years ago, now quite a way down the line, 10 years ago, I kept collapsing and being taken by ambulance to hospital. And it was very variable, the sort of, you know, the experience within A&E. Sometimes it was very thorough, sometimes it was certainly less so. And in fact, it took, because the episodes were not connected, and dare I say it, what I said about my symptoms were not really taken account of because they were slightly unusual. Took ages before a diagnosis was made, and that made such a difference to me because I'm fine now. But you know, it really is important that elderly people who often don't have very typical symptoms, or they don't have them in all cases, really do have a full and accurate history, and that there are connections. If they attend A&E, certainly, I believe that they should be seen by their GP, evaluated, etc. And I think if we planned and followed the care pathway model, we would actually save the health service a lot of money, and patients would be treated much more satisfactorily. And there we are at the bottom, 48% of older people being admitted to hospital. I've got to cover an awful lot in half an hour, so I'll have to move on a bit. And what do elderly people want when they attend A&E? This is not out of my mouth. It's one of the, it's from a presentation by one of the gurus of elderly care. They will want to be seen promptly, to be treated with dignity and respect, of course, and understand, and then particularly now in our multi-ethnic society, doctors need to be able to cope with all the variations of problems that might present, and an understanding of individuals and their culture, and that obviously can be quite difficult in A&E. And if they are admitted, yes, certainly, they need to be informed about what's going on. And I think actually, on the whole, I would say from my experience, that's been handled well on the whole. What do elderly patients require following admission into acute care? This is a list that you physicians would know very well, but it often falls down. Geriatric assessment, rehab, discharge planning, medication management, very important, communication, and also at the bottom, competence in the care of dementia, because obviously there are so many patients in hospital with dementia. Absolutely vital that the clinicians seeing the patient and the nursing staff and all those involved do understand dementia today. I would just say there, I think I say it somewhere else in the slide, but I might have to speed up, that people with dementia, they're all different. My mother is totally different to my husband in the way she behaves. Although my husband's memory loss is now it's now about the same as my mother's. Hers has been very slow. Her first, the first sign of any memory loss was as far back as 1994, and I know that because she stopped paying her accounts on her store cards. And I was looking through the, when I was clearing my parents' house, and I just found how the pattern of her behaviour, you know, it was quite obvious she was getting a certain amount of memory loss. And when my father died in 2000, she and they were living at home, and he had heart failure and was on continuous oxygen. She was absolutely driving him mad by her repetitive questioning. So it's been a very long road for her. But my husband's has been about 8 years so far, and he's at the advanced stage now. But it's certainly, there we are, I keep pointing it at the screen. Now, increasingly, patient safety is a big issue for older patients in hospital, as we know. They've got less reserve, and the high volume safety incidents and harms predominantly affect older people. That's infections, falls, etc., etc. I don't have to tell you what these are, but they're at the bottom. And that's David Oliver, Managing Risk in Older Hospital Inpatients. Clinical risk, and that is now. I'll just mention that clinical risk is published by the RSM Press, and it's a very good journal on risk management, patient safety. It covers legal issues as well as the clinical issues, and it's in fact specialising. It has this edition is all about elderly care. And it's just come out, so I picked that off the press very quickly. Older people with impaired mental capacities, inpatients. Well, I've mentioned that, so I'll push through that. But they do need psychiatric assessment in hospital as part of their treatment and care. Now, I'm pushing forward, as I've said, quality care for older people with urgent and emergency care needs. There's a silver book out. Many of you will know about this. The authors are there. And that was a source document. When I actually talk about patient and public involvement generally for this organisation. So I had to put together new slides, and you do a search on the web and all the rest like people do, and I found this very good silver book, and I thought it was very good. So if you don't know about it, I should have a look at it, because really, you know, it can give you all the answers or tell you all that you have to do. And the underpinning principles behind the silver book is there. Respect for the autonomy and dignity of the older person. It must underpin our approach and practice at all times. Older people have the right to health and social care assessment and should have access to treatments and care based on need without an age-defined restriction on services. And you know that's very important now, because that's going to be legally binding. And then the other underpinning principle, whole systems approach with integrated health and social care services. And that is so important. When we talk about improving care of the older people, it really is about joined up thinking, about professionals not working in silos, about GPs taking responsibility for their patients and watching them as they go through the system and out the other end. And really, to me, that would be the pleasure of clinical care. I know when I was a nurse many years ago, we had, you know, it was a long time ago, we had patients in for months and months and months. And you knew them so well, and that helped you to provide as safer care as possible. You knew their relatives, you knew their social history, you spoke to them every day. And you had such a super professional relationship with them. And now that's gone. And with people working in silos and the pressures of work, all the rest, it makes life very difficult, both for you as professionals and the patients, who really just get pushed around the system and half the time don't know what's happening and what they should be doing, etc., etc. It is that bad for some patients. Patients who are on specific pathways for specific conditions, they're about the luckiest sometimes, you know, rheumatology or diabetes or oncology. There are often specialist nurses attached to a team, and that's where it works the best. But the bog standard patient arrives in front of a GP. Generally, I would say, often gets very fragmented care. And this is what older patients should be routinely assessed for. And again, is it always done? But that's standard, obvious. Then medication management. I was asked to speak about an awful lot of subject areas. So I just sort of cobbled together very quickly, because it's a vast area and I'm pretty interested in it actually. I did some research with locally some years ago, and on the interface between acute and community care for the local authority, and it really is an issue, because MRPs, medicines related problems, cause 5,000 deaths per year in England and have an estimated cost of 750 million. Published data suggests 2/3 of patients in the UK do not receive information about the side effects of their drugs prior to leaving hospital. Up to 20% of hospital admissions may be related to MRPs, and poor communication between services is a recognised problem. Yeah, I've had experience of that myself, but I won't go into it. I was involved with one of our local hospitals with the NIHR Clark project. That's I can't remember what the terminology is, leadership program, but anyway, it's a research program, and it's NIHR, National Institute for Health Research, funds certain projects. And I was involved as a patient with West Middlesex Hospital on a medicines management project to improve patient safety across the divide between community and acute care, and also by providing patients with a lot better information and understanding, and also connecting with the community. And there we are, project drivers were these high figures. Errors can occur on admission and discharge, particularly with the elderly. As you well know, patients don't always carry have a note of their medication in their handbags or whatever, so they arrive at an emergency department, obviously have chronic health conditions, and it's quite difficult out of hours to find out what medication they're on. All sorts of things can go wrong there. And well, with this West Middlesex project, they involved pharmacists who did checking at certain stages through the process of a patient's episode of care within hospital, and it greatly improved the situation in regard to efficient management of their medication in hospital. And it showed that we had sort of graphs, because there were records, it was all on the system, and obviously they took the results out of the system on a regular basis, and it was quite interesting to see actually where junior doctor changeovers, etc., you know, there'd be a big dip in the well, many more problems. So it was a very interesting exercise. And so there we are. That was what they were trying to improve on. And then they had, I won't go through all this, but they had a very good discharge medication counselling checklist. They went through it with every patient on discharge, and it was carried out by the pharmacist. I think in all cases, I can't remember from memory whether nurses ever did it, but it was certainly by a competent person who knew about the medication that the patient was on. I think it was mostly pharmacists. Really worked very well. Now, I was asked to talk about standards in nursing homes. And CQC has some national standards for care, which are pretty standard. But the nursing home my mother's in is in the West Country, and it's an old Georgian house and very old-fashioned. But they got the top rating when CQC was, they've stopped the star system now, but they got their 3 stars. To me, and observing over the years, my mother is an extremely difficult person and went completely, what shall I say, acute confusional state recently with a UTI, which, as physicians will know, and surgeons no doubt, and nurses and all the rest know that it can really disturb elderly patients. But I think the issue of what you want in a care home is leadership. I mean, that's absolutely fundamental. If you've got a good manager at the top, and ours is a sort of old-fashioned nurse, and she's really got those qualities of looking after the staff, looking after the patients, expecting very high standards. She just won't employ anybody that doesn't come up to her standards, and she's got a very stable staff. Quite a few of the staff have been there all the time that my mother's been there, and she's now been there 12 years. It was her choice. Self-funded, I might say, because I could go into the issues around funding with an joined-up system, which is really going to be an issue. So I'm not going to read those out because they're standard, but we know you can have standards, but they're not always followed. By no means are they followed. But to me, it's leadership, quality of staff, not so much the environment. They work in quite a difficult environment with a cranky old lift, but they are very kind and have managed my mother very well. Right, oh dear. I've just got a few slides at the end. These are more general, but the operating framework for the NHS, putting patients at the centre of decision making, experience of patient service users taken into consideration, etc. And it's a mantra, isn't it? National Institute for Health and Clinical Excellence, NICE, committed to involving patients. It is getting better. And here we are. This is good. If you should know it, I know, but you know, people don't always keep up to date on standards and protocols and all the rest. NICE has a quality standard for patient experience and adult NHS services. It actually is pretty good. It's very detailed, and now sitting outside the NHS, I just, you know, it's a big ask if you're going to achieve every standard. But it's there and it's sensible, actually. I mean, it's a good working document to work towards. So I would say at the end of the day, and it is about improving care, you all need to think as professionals about how you can join up your expertise better. That's the only way it will work. I see so much waste from, you know, just a community point of view, talking to patients about delays and repeat appointments that aren't necessary. Not seeing the right person could be an issue. And it really is a patient safety issue. You can have a surgeon take out the wrong kidney and it makes the headlines, doesn't it? But actually, you can have a delayed diagnosis for a patient or no diagnosis at all, and you know, that can kill the patient equally. So it's the mishaps along the way that are just as serious as the sort of headline-grabbing problems. And I know from experience, if you go into the health service, and I think many of you will agree with this, if you've had experience of being a patient, I don't think there is any perfect episode. There's always something that goes wrong. On one episode, I mean, just to finish, elderly patient collapsed, and I'd done it twice. So the second time, there's me, and I look at my armband, and it's got the wrong name on. So no wonder they couldn't find my past records, and I was a bit confused because I had collapsed. I couldn't remember when I'd been in, so I probably thought I got early dementia or whatever. And then I can't remember if I was admitted on that occasion, but I think I was. And yes, I was admitted to acute medical unit where they had these multi-professionals. They've stopped them now, and they were physios in charge and had a certain amount of training, and so could give medication. And without really knowing what was wrong with me, because I went in with these certain symptoms, they gave me a pretty bog standard drug, and I collapsed, and the next thing I know, there's a cardiac arrest team around me. So that was pretty distressing for my husband. On another occasion, I queried a drug for a test that was going to be happen the next morning, and the little nurse came at night and wanted to give me this medication. And I said, I don't think it's due till the morning. And she queried it, on the sheet, and she said, no, I've got to give it now. Well, of course, it was an error. So that caused me distress and a day extra in hospital. And and also another, in relation to the armband, that caused a delay because the blood forms had been written up in A&E. The phlebotomist came to take my blood the next day, and she couldn't take it because the forms were in the other person's name. So that delayed the situation. Now this is ridiculous, but one just wonders how often these minor mishaps go on. I mean, I was all right, I was told I hadn't got a heart attack when I found myself in intensive care for a while. But it really, it sounds a bit like a comedy show, and I take it in all good part, and I know things go wrong, but I don't really think that any episode goes absolutely smoothly. And the more we can smooth out the mishaps along the way, the better. And it will be much safer practice and save the NHS an awful lot of money and be a lot better for the patient and the carer. Just an issue about funding before I go, and I've got to go, so I've got to go somewhere else for another meeting. You in the health service and often not as aware as you need to be of the issue about the differences between health service funding and social care funding. And that's going to be a big issue to address when we look at integrated services, which is the government's agenda, and obviously would provide better care, particularly for the elderly, because a lot of elderly people are self-funders. So if you're going to think up, if any of you are thinking up these models of care, where you have a mix of acute care and acute care in the community, perhaps more than acute care in hospital, but it might apply with certain models of care. But acute care in the community, and you're expecting the social care to come together with your ideas, that's going to be a bit of a stumbling block, and I raise it all the time. There is a lot of work being done at top level at the moment about the future funding of social care, but I don't think it will ever be free, and I'm not suggesting it should be, but it's a major issue for you just to be aware of, because a lot of people that work in the health service don't understand the impact of the different funding streams and how it's going to affect your integrated working practices in the future. I think that's the last one. Anyway, we've got to finish now.
Margaret, thank you so much for both sharing your